we talked about essentials for pelvis. We're going to talk a little bit about essentials for acetabulum. So our learning objectives here really are to understand anatomy again. We're going to spend a lot of time with anatomy. I cannot emphasize how important getting a pelvic model and hanging onto it are, particularly when you're on the trauma service. It is just, I'm still learning about the anatomy of the pelvis. I learn about it every day. When I go to, last week when we were in the IR suite, I'm still learning about the vasculature of the pelvis. I mean, this is such a complex topic, and it is so important for just fundamental understanding, communication, and decision making. So it's really the underpinning of everything we do. And we're going to talk about operative and non-operative indications, because again, these are the questions that come up on your tests. They're understanding what needs surgery or what may benefit from surgery is a lot more important for you right now than the more complicated, involved techniques of actually getting that process done. And we'll talk about some surgical approaches as well. So first thing we need to know is that the acetabulum is comprised of columns. There's an anterior column and a posterior column, and this is an original drawing from Letournel. And he described how these two columns encase the articular surface of the acetabulum. And at the apex of these two columns is what we call the sciatic buttress, which is one of the hardest columns of bone in the whole body, and help convey that weight-bearing load from the lower extremities up to the axial skeleton. Okay, standard radiography and surface anatomy were really worked out to a great degree by Judet and Letournel in their classic book and articles. And basically how they did this was they would take a pelvis. They would either lay a band, like a piece of lead tape on a surface and X-ray that and see what that surface actually was associated with on a radiograph, or they would just erase areas. You can see how they kind of eroded or just kind of carved out the quadrilateral surface here, and they would take an X-ray and see what that did to change the appearance radiographically. So a lot of this stuff that we teach you now is based on these techniques back in the 60s, late 60s and 70s. So first thing we do, again, just like pelvic imaging, is we focus on plain radiographs because they're less distracting and they help us begin to understand and detect problems. And don't ever forget, unless the patient has bilateral injuries, that you've got a template for normal on the contralateral side. What are we looking for here? Well, there are typically 6 lines that I look for on an AP pelvis when I'm trying to understand an acetabular fracture. The first is this sourceal, or what we consider to correlate with the weight-bearing dome of the acetabulum. Okay. We also have the acetabular wall. So you have the anterior wall, which lies a little bit more medial, unless the patient has acetabular retroversion, to the posterior wall. And you can see both of these lines on an AP radiograph. We also care about the iliopectineal line, okay? And this is meant to tell us about the anterior column of the acetabulum. And you have the ilioischial line, which tells us about the integrity of the posterior column. Finally, we have this thing called the teardrop, and this tells us a little bit about the medial wall of the acetabulum. If anybody can tell me the 3 structures that actually stack upon one another in order to give us the appearance of the teardrop, I'd love to see it. Put it in the chat or email it to me, and you get a little prize. Okay, now we also can't forget about the inlet and outlet imaging that I was telling you guys about earlier. You can use those images just like you can the Judet views or the oblique views to tell you or give you information about the acetabulum. And what I want to show you here is the way that I look at the pelvis, and particularly how I look at it with respect to the acetabular wall and columns. Okay, what we see is that which is perpendicular to our line of sight. Okay, so if I go back here and I'm looking at an obturator oblique. Okay, this would be an obturator. Now I'm looking at more of an inlet projection here, but my eyeball is actually looking at the pelvis from an oblique plane of view. Okay, and if I were looking at the obturator oblique, okay, what I would be looking at, what I'd be seeing is the posterior wall and the anterior column that are perpendicular to my line of sight. If I look from the other direction, I roll the pelvis the other way, I'm looking at the iliac oblique. Now I don't see the anterior column and the posterior wall so well. I see the anterior wall and the posterior column. Okay, let's take a look at this in a little bit more detail now. Okay, I've rolled the patient. Now we no longer have an inlet projection here that I was using to show you that schematic. The patient is rolled away from me, okay, and the image is taken, and this shows me again the posterior wall and the anterior column, because those are the structures that are perpendicular to my line of sight. If I roll the patient towards, if I roll them the other way, okay, now I see the ilium en face, right? I also see the anterior wall and the posterior column, okay? So I want you to think about how the patient is rolled, how that impacts what is perpendicular to your line of sight, and what that means in terms of the structures that you can see most clearly. Obviously, CT scans are very useful for further precisely defining the injury, but again, I think they can be very distracting if they're the first thing you start with. So whenever possible, start with a good set of plain radiographs. If you can get Jude views or oblique views, that's even better. Now a lot of what is done is that the true Judays, where the patient is actually rolled up onto a foam block one direction or the other, are being substituted by these ghost reconstructions, and that's all fine and dandy, but the problem with those is that they don't actually give you the displacement that you get from actually rolling a patient in one direction or the other. So it's more of a static versus a true Jude being somewhat of a dynamic stress of the acetabular fracture. An anterior column is on this pelvic model here is what you see in white, okay, and we're looking at it both on an obturator oblique and an iliac oblique here, and you can see what an anterior column fracture looks like. It's comprised of the proximal aspect of the pubic ramus. It includes the anterior wall and the crest of the iliac crest, and we have what are called both low and high anterior column fractures, that, and depending on whether they exit above or below the ASIS. Posterior column is shown here in red, and you can see that it includes everything from the ischial ramus, the bottom of the ischial ramus, onto the ischial tuberosity, posterior wall of the acetabulum, the iliac spine, and extends proximally up to where it meets the anterior column and the ilium at the greater sciatic notch. Let's put this all together now. So we have elementary type fractures, and we have type fractures, okay? And these five are really important to think about. These were described again by Letournel and Jude, and really give us the language that we need to talk about the most common acetabular fracture patterns. This is not 100% comprehensive, but it's really stood the test of time and is very effective in terms of allowing us to both communicate with one another about what we're dealing with, as well as making surgical decisions. Okay, and another question that I have for you that I would love an answer for is if you can tell me the elementary and associated type fractures that involve both the anterior column and the posterior column. Remember, I'm not talking about the associated both column, which is a particular associated type, but I want you to tell me in the chat which elementary and which associated type fractures include injuries to both the anterior and posterior column. All right, how about decision making? We're going to wrap this up in the next 5 minutes. So we need to take this information about what we've gotten in the workup of the patient, an understanding of anatomy, and clinically relevant imaging, and help decide who needs surgery and who doesn't need surgery. Okay. We'll use this information to determine who needs traction. How about when to operate, what kind of surgical approaches we need, and how the reduction and fixation is going to work, as well as post-op treatment. Obviously, the decision-making process is modified by host factors. Age really makes a difference in terms of whether that patient is going to get surgery, what kind of surgery they're going to get. Is it going to be ORIF? Is it going to be CRPP? Is it going to be a hip replacement, right? Pre-injury activity level matters a lot. Comorbidities matter a lot. Obviously, the availability of a surgeon who's skilled in this kind of surgery makes a difference. Okay, a lot of questions have been coming up about traction. So who needs traction? Well, the idea behind traction is what? It's preventing ongoing chondral injury from displacement and aberrant pressures on the femoral head cartilage or acetabular cartilage due to displacement and step-offs and even dislocation. So obviously, any patient who has a truly unstable acetabular fracture is going to benefit from traction. You need to get that joint back in, and you also you need to get that patient in traction to try to take some of the pressure off of those broken acetabular fragments, as well as to keep the femoral head in joint. Any sort of acetabular fracture that has medial subluxation, and this includes the transverse family of injuries, as well as T-types and associated both columns, those patients benefit from traction. I would say, when in doubt, just do it. I've never had a problem with somebody putting in traction for an injury that may not have 100% needed it, but definitely the converse is true. Operative indications. Who needs to go to surgery urgently? Well, open fractures need to go to surgery urgently. Irreducible fracture dislocations, and those patients who have significant intra-articular debris, those patients are going to need surgery. The decision in those patients is not if, it's really when. Less urgent is patients that have some degree of instability or displacement, but can wait for surgery, and those patients can go into traction. This was a patient who presented in the last month or two at San Francisco General Hospital and sadly sat in the hospital over the weekend dislocated. This is not something that ought to be sitting around the hospital dislocated for more than a couple of hours. You can give this an attempt at a reduction, but if this is not going back in, this needs urgent surgical attention. Okay, stability. All right, so how do we define? We talked about stability with regards to pelvic ring injuries. In acetabular fractures, stability is assessed or determined by a loss of congruence. So if you lose joint symmetry, and often you need to look at the other side. If you've got a CT scan and you can see both sides, or a good X-ray of both sides, you can tell how much clear space is there in a joint, and if that's being affected by the acetabular fracture, that's an unstable injury. Sometimes it can be subtle. If you have any subluxation of the femoral head, that's an indication for surgery. Okay, how about displacement? Well, it matters where the fracture is displaced. Okay, so displacement is most important when it's happening through the weight-bearing dome of the acetabulum. So any displacement, people used to talk about 1 millimeter or 2, but if there's displacement through the weight-bearing dome of the acetabulum, that has been negatively associated with outcomes long-term, and those need surgery. How do we determine if the weight-bearing dome is involved? Well, There was something that was described as the roof arc angle in the era pre-CT scan, in which we would take a horizontal, we would drop a perpendicular, we would draw a line from the center of the acetabulum, not the femoral head. Remember, we're trying to determine the center of the actual flat most extent of the fracture, and if that was within 45 degrees, that was determined to be unstable. Now that's been looked at in the CT era, and we consider that weight-bearing dome to be the upper 10 millimeters. If you're studying this on a CT scan, you ought to be thinking about how thick your cuts are, and you can calculate this down from the subchondral bone of the acetabulum. If that's involved, that's an indication for surgery. So patients that can be treated non-operatively are congruent on all three views of the acetabulum, AP, iliac, and obturator oblique. They have displacement of less than 2 millimeters within the weight-bearing dome. If the fracture is displaced more than 2 millimeters, that ought to be below the weight-bearing dome. Okay, and when you're in doubt, just like in the pelvis, dynamic stress examination can be very helpful. Okay, non-operative treatment, we're not going to get into a lot here. We'll talk about, operating again when the patient, determining when operations are, we'll do this when the patient is medically stable. The surgeon obviously needs to understand the fracture and develop a tactic to get after it. And we need to find a operative team that's available and able to take care of these patients. We used to operate on these fractures very urgently. It's been shown that you can delay treatment safely for several days or even a week and still achieve good outcomes. But this notion that you're going to avoid excessive blood loss if you operate too early is also not the case. Okay, so surgical approach is a little bit more of an advanced topic, but I'm just going to go through some of the two most common approaches that you're going to see here. The Coker-Langenbach and the ilioinguinal and its derivatives are most common. We're not going to talk a lot about extensile procedures or CRPP in this talk. Those are a little bit more advanced topics. Generally, we think about the Coker-Langenbach or the posterior approach as an excellent means of seeing the posterior wall and posterior column. Okay, so this is a transverse fracture that involves both the anterior and posterior columns, as well as a posterior wall fracture. And you can see here that this was all done through a posterior approach. The ilioinguinal and its derivative, the one that I use is the kind of the classic lateral and middle windows of the ilioinguinal with an anterior intrapelvic approach substituting the original medial window of an ilioinguinal. This is a great way to see anything that has to do with the anterior wall, anterior column, and most transverse T and associated both column fractures. Okay. Occasionally, we need to combine these two approaches. If anybody was at the general with me on Monday, we had to combine both an anterior and a posterior approach to treat a very challenging associated both column injury. This is something that this is going to be something we have to do when it's just not enough to see only one surgical approach. It doesn't give us the visibility that we need to address all of the important components of an injury. All right. The only thing you really need to know about fixation at this point, and this is a common question in the operating room, is what is the function of most plates that we use in the acetabula that tend to be buttress plates. Screws alone can be used in patients with really good bone and minimal comminution. Often this is an approach that's being used with percutaneous techniques, and you need to have bone graft available in settings of marginal impaction. All right, so in conclusion, remember that the displacement within the weight-bearing dome and loss of congruence really are your main indications for operative management of acetabular fracture. And the fracture pattern, understanding those 5 elementary and 5 associated type acetabular fractures, really help us determine the surgical approach. All right.